Good morning or good afternoon whenever you're watching this video. We're going to review airway management, specifically intubation today. So a couple of things that you'll note. I have a couple of notes here to tell you guys. Hopefully remind me in class, but we'll talk about making sure the correct technique for laryngoscopy, that you don't do certain things, and perhaps I'll touch on it later, but in regards to avoiding hitting somebody's teeth and medications that can be administered through the endotracheal tube. We're not necessarily doing that in the pre-hospital setting, but that said, there are certain medications that you can administer through the endotracheal tube. So I don't know on this lecture, I don't think that I will cover that, but please note there is a list of medications in your textbooks, and you should know the ones that you can administer. In the hospital setting, we will give lidocaine and epinephrine quite frequently during bronchoscopy procedures. So you need to know which medications can and cannot be administered through an endotracheal tube. The acronym is NAVAL, so go ahead and look that up. Okay, so here are your learning objectives. Hold on. Here are your learning objectives. Make sure that they're the same as what's in your syllabus. The syllabus will always trump what's here, but they should be the same, but just in case there's an extra one in your syllabus or something like that, please make sure that they're the same. Okay, so in terms of the anatomy, I'm going to just kind of briefly touch on it. You have already been provided your anatomy and physiology class, so this should just be review for you. If it seems like you've not seen this before, then you need to go back to first semester RCP 52 and review this information. Part of intubation procedure is knowing the anatomy and being able to identify whether you have what appears to be a difficult or not difficult intubation. And so that's important for us, because if we anticipate a difficult intubation, we have to gather additional equipment to be prepared for that particular scenario. So Brady's 5 Ps are: proper preparation prevents poor performance. Okay, and that's Brady Scott, who's a up-and-coming Bob Kazmarek in respiratory care world. So he's like, and Kazmarek is one of the authors for EGANS. If you don't know who that is, then he's like a legendary contributor to our profession. And so Brady Scott is heading in that direction, and you guys have already heard some of his lectures, whether you know it or not. So that being said, go back and review. You have to be familiar with the airway anatomy. That's just bottom line. Okay, here's a picture of what it would look like. So in terms of the bottom picture, when you are inserting your laryngoscope, and I'm going to review that in a minute, this is kind of the view you're going to see. So I recommend going online as well and looking up different YouTube videos or pictures or images of what this is. A drawing, so it's not similar, the real thing is going to look different and people's anatomy are different. So I would recommend going online and reviewing what the actual anatomy will look like on a human being, so that you know what is being viewed as the intubation procedure is happening. Okay, so just some sensory innervation things. The glossopharyngeal nerve, these nerves play a significant role in your gag reflex. And so definitely when we are doing our intubation procedure, we are paralyzing. Patients will get paralyzed by a short-acting paralytic, commonly given succinylcholine. And the reason they give that particular med is because, again, we have to depress these gag reflexes if they're still intact. So unless a patient's completely out of it and they don't need any sedation or paralyzation, which is rare, then you have to provide them with some kind of sedation. And typically we will even paralyze, and succinylcholine is typically utilized because it's so short acting. So a lot of the other paralytics that we have are more longer acting. So you don't want to paralyze somebody for 2 hours. We just want them to be paralyzed momentarily just while the intubation procedure is going on. But anyway, that being said, the gag reflex and cough reflex are significant airway protection reflexes, and they're very important to protect an airway. And so also when you're evaluating whether somebody needs to be intubated is if they don't have these reflexes, then they're not able to protect their airway. And an inability to protect the airway is something that would be an indication for intubation. Okay, and just some additional information about, you know, what cranial nerve is innervating what. And that's important, especially because when somebody comes in with like a head injury or something, these are some of the ways that they can evaluate which nerves are intact and which ones aren't. So anyway, I think it's important to be aware of this. You know, one of the other complications, you have laryngospasm, other type vocal cord spasm, things like that. So I think, again, that's because these nerves are innervating these certain areas, and stimulation can cause some complications. Okay, so airway exam. So before this intubation procedure, so this is kind of looking at it from an elective perception. So we call it an elective intubation when you kind of plan it in advance. So sometimes, you know, you have emergent intubations. That's when you're not planning it. Somebody just, you know, codes or something happens. You don't necessarily are capable of performing a full airway exam. Okay, so this is referring to an elective situation. Like an elective intubation would be something like the person's in failure, but they're still awake and alert, and you kind of talk to them and like, okay, are you willing to have a breathing tube placed, and yes or no, and you can do things like that. You can also get the family members to help you with some of these things. Surgery, for sure. I've had surgery before, and the day before, 2 days before, I've had the anesthesiologist call me and ask me some questions, and that would be part of the you know, history gathering piece. Okay, so looking at this, airway examination is very important. If you can talk to the patient, you know, these are some things that you would want to know, like, do they have a history? Have they been intubated before? So if it's an asthmatic patient, especially an asthmatic patient, if you have somebody coming in with an asthma exacerbation and they're like, oh yeah, I've been intubated before, red flag, okay? Because if they've been intubated before, then it's likely that they'll get intubated again. They're more likely than other asthmatics who have not been intubated to get intubated again because of asthma. So that said, if somebody has a history of a difficult intubation, that should be a big red flag, okay? And so some people can tell you, like, you know, oh yeah, I had surgery and the anesthesiologist said that, you know, they had a difficult time getting it in, or, you know, I had, my throat was really sore, I had a broken tooth, or whatever, like anything like that, that means that they had a difficult time getting the tube in. And if they have a history of a difficult intubation, it's likely that they will be difficult again. So at all possible here, this is where you would gather like additional stuff to make sure that if you get into this scenario, you have everything you need right there and it is a disaster averted. Okay, because let me tell you, when you have a difficult intubation and you do not have the appropriate equipment available, this is high stress and it can be disastrous. Okay, so you absolutely want to be prepared. This is no joke. This is a person's airway. They will die if they don't get an airway placed. Okay, that's the bottom line. So history of difficult intubation, big red flag. A diagnosis of OSA, that is another red flag, because those patients tend, and not everybody, but patients with obstructive sleep apnea tend to have more anatomy than others. And so like a higher Mallampati score or whatever, again, this is things that lead to difficult intubation. So anything that could help, you know, make you think that the patient might be a difficult intubation. So this is what you're trying to establish when you're performing your airway exam. So if they have an OSA, that could be that they have more anatomy, there's not as much visualization going on, it might make it more challenging to get the tube in. So say this, temporomandibular joint disease, or TMJ. This is where they cannot open their mouth very wide. So again, that can lead to a difficult intubation because everything depends on the patient having an open, clear airway so that you can go in there and take a look and put the tube in, okay? Previous airway surgery would be significant in case of any kind of anatomical changes, or perhaps a scar tissue, or if it's been a recent surgery, if they have like sensitive areas, that could be a potential area for hemorrhage. Okay, and any anatomic abnormalities of the head, neck, or airway. So people who have like kyphosis or kyphoscoliosis, or if they have like osteoporosis and then let's say they're like stuck like this, you can't extend the head and the neck back in order to do your head tilt chin lift. So if they can't do this, then it's going to be just more difficult because now you're trying to get the airway in like this. And if you look here, it's like the curve is like this. So, I mean, you want to be able, anything that prevents you from structurally being able to extend the head and the neck is going to be difficult. Micrognathia is a small jaw. So again, being able to do the jaw thrust, and if they have a small or a recessed jaw, that again just pushes the tissue back and makes visualization more difficult. And same thing with a small mouth opening or a significant overbite. So anything that could potentially be a challenge to head tilt chin lift or opening the mouth and visualizing, if there's too much tissue in there, makes visualization difficult, leads to a potentially difficult intubation. So one of the terms I talked about, an emergent intubation, the other term they call it is rapid sequence intubation, or RSI. So make sure you're familiar with that term. So a rapid sequence intubation is like not going to be able to do all of this. It's kind of an emergency scenario, and basically they're just going to go ahead and stick the tube in because without performing the ideal scenario of a full airway exam. But a rapid sequence intubation is typically where you get all your supplies ready, they go ahead and they sedate and then paralyze the patient. One of the things that I've seen people do is when you're trying to figure out, like, did the paralytic kick in, is that they will go and take a thing and they'll brush your eyelashes. And then if the patient kind of flinches like that, then obviously it's not working yet. But if you do this and they just are out of it, then that's one of the things where they're like, okay, let's go ahead. So I've seen them do that as part of their rapid sequence intubation. Okay, so continuing on this airway exam, the Mallampati scores are very important. So you need to know these. You need to be able to classify Mallampati. We've introduced this in first semester, so this should be review, but you have to know it. And basically, the lower the score, the better. The higher the score, the less you can see. And so it means that when a person opens their mouth, you're basically seeing what you can see. And if the lower the visualization, the higher the score, that means the higher the probability of a difficult intubation. That's not to say that someone with a class 1 would not be difficult. Anybody can be a difficult intubation. What you're doing is evaluating the risk of a difficult intubation, and these are some of the criteria that would be more likely to be a difficult. So you can have people who are a class 4 and it's an easy intubation, and you can have somebody with a class 1 and they're super difficult. It just depends on the situation, and you know, things happen. But that being said, the more likely the patients who are difficult have these kind of risk factors. Okay, so how do we go ahead and start looking at, placing this airway in place? So, the head tilt chin lift, right? So the sniffing position, you want them to kind of extend the head. And so you're kind of like looking, if you look at the airway, it kind of goes, I don't know if I'm seeing it. Okay, it goes like this, and then it's like this. So it's kind of a 90-degree turn, and your trachea is more anterior. So what you want to do is make it so that you can visualize the vocal cords. So they talk about the sniffing position because, see, I kind of reduce the angle by doing this, okay? I reduce the angle. And then if I tilt the head up, I make it even more, less of an angle, okay? So just kind of think about the angles and what's going on. That being said, some of these ideal scenarios where the perfect positioning of the patient, you can't necessarily do. So a contraindication for sniffing or head tilt chin lift is an unstable cervical spine fracture. Okay, so you just can't do that. The only thing you can really do would be like a jaw thrust in that case. So a jaw thrust is just where you push the jaw forward, and it's supposed to put the tongue off the back of the throat and help. The visualization is very difficult with just a jaw thrust, okay? So you can see here some of the contraindications, of course. TMJ, if they can't, do this. An unstable cervical spine, I think they still do it. I mean, I think we talked about having some opposing pressure. So if a patient has an unstable cervical spine, you might be thinking, what can we do? Like, we can't even do anything. They come in, they have the collar, you do not take the collar off, okay? And basically anyone who comes in with an unwitnessed, if they're found down or anything, and you haven't witnessed it, you assume a cervical spine fracture until they're cleared. So where the law says innocent until proven guilty? Well, that's the opposite for cervical spine fracture. It's basically guilty until proven innocent. So you assume they have a cervical spine fracture, and you treat them as such until like a CT scan or something can clear them. Okay, so because we don't want to make it worse if they, if they have it. So anyway, that being said, we have some difficult airway adjunct devices that we can use. And so typically the best way to intubate a cervical spine person in the hospital is to use bronchoscopy. And this is where we have a scope, and the scope is, it can bend through all the different airway anatomy, and you put the tube on it, and then you put the scope inside into the lungs, and then you just slide the tube in over the scope. And so we can look at that a little bit later, but right now we're kind of just talking about more like a standard intubation, but you do need to know what the contraindications are for some of these positions. Okay, so main thing, we want to get the tongue out of the way so that we can get back there and put the tube in. Okay, here's what the sniffing position would look like. And again, we're kind of just looking at these angles. So again, if you look here on this patient who's just flat, it's like boom and then boom, right? So it's like almost a 90-degree angle to try to get in. When you look at this one, it's a lot more, the angle is a lot less severe. So it's just positioning of the patient is going to be critical. It's going to be critical in order to successfully place an endotracheal tube. I've seen people, instead of putting towel or whatever under their head, I've seen them put it under their shoulders, and perhaps by lifting this part of the body up, you can still see okay. Again, I just say my thing is whatever you can do to keep the patient in the optimal position, the easier the intubation. And so you want to intubate on the first time, and you don't want it to be like 3-4 times later. And that whole time the patient's, airway isn't established, they're desaturating, it's stressful. I mean, so anything you can do to make it the best case scenario, that's the best thing to do. Okay, so this is a picture of somebody performing a jaw thrust. Okay, so where your angle of the jaw is right here, you're going to put fingers behind the angle of the jaw and then push out, okay, and push forward, and then you are pushing the jaw up. That's funny. On the other slide, it says that a contraindication for jaw thrust, or, oh, the chin lift is the contraindication for an unstable cervical spine. A jaw thrust is okay. Chin lift is basically where you grab inside and you just go and you pull the chin forward, but you can see it would move your head forward too. So we wouldn't want to do that with unstable spine. But for a jaw thrust, that's okay. If you're kind of just holding it like that, you can do a jaw thrust with unstable cervical spine, because you have to do something. I mean, you have to be able to ventilate them some way. Okay. This is the chin lift. I don't agree with what it says. I don't think that it can be done unless you're like holding their head down and going like this. But I don't see why you would ever put your finger in someone's mouth. The only time I would ever do this is if the patient's completely out of it and I was trying to insert an oral airway. Okay, so as you can see, this looks extremely dangerous. Okay, so you got to be careful here, and just make sure the patient's totally out of it and that you're not going to risk losing your thumb. I don't know how often this is done. I don't think it's done very often at all, but I do need you to know about the different ways of trying to open an airway. Okay, so routes. We've got different routes of administering an airway, or different routes of establishing an airway, I should say. So you have your orotracheal and nasotracheal, and then just regular old tracheal, which would be a tracheostomy tube, which we've already covered, okay? So this is, again, talking about establishing an artificial airway via intubation. And so you either go through the mouth or you can go through the nose, okay? Okay, your endotracheal tube is what you use to go in through the mouth or through the nose, and a tracheostomy tube is the one that goes directly into the trachea. Okay, so we've already covered tracheostomy tubes, so you do need to know those. That's not my focus for this lecture, but again, it is part of airway management, so it's still included in here, but I am not going to focus on that in this lecture. So here's your types of tubes. So the first one, this one should look very familiar. This is your tracheostomy tube. Here's your endotracheal tube here, okay? So you do need to know the parts of an endotracheal tube. And I might have one coming up. I do have another slide coming up where it kind of goes more into detail and shows you the different parts. Okay, endotracheal intubation is your most reliable method of ensuring an airway. So the other ones that we've covered in this class so far are supraglottic, meaning above the glottis. And those include LMAs, or laryngeal mask airway, oropharyngeal airways, or OPAs, and nasopharyngeal airways, NPAs. Those are all considered supraglottic, and they are not, they're temporary measures until you can get an airway secured. So they're not secure airways. An endotracheal tube is a secured airway because it goes directly into the trachea. It sits in there. The cuff will seal off the airway, and therefore you can intubate and have all the air go directly into the lungs and not into the esophagus and into the stomach. So it is more reliable and considered like a secured airway, okay? So purposes of intubation, so ventilation when high pressures are necessary. Let's say their compliance is so low, or they have really stiff lungs and they're not able to successfully ventilate using normal spontaneous ventilation or bag mask ventilation. You need that cuff to really seal off the airway to force the air to go into the lungs. Direct access to lungs for secretion removal. So copious or unmanageable secretions is another indication for intubation if they have if their disease process is such that they're just not capable of removing secretions enough on their own and they're basically like drowning in their secretions, then you can intubate them for that. Drug delivery, again, we wouldn't intubate just to give a drug, but you can give drugs through the endotracheal tube, and all of our same inhaled meds like albuterol and Atrovent and whatever, they can all be administered into intubated patients too. We also can give inhaled antibiotics, and then as I mentioned, the nasal meds, you can give those meds through an endotracheal tube too. Okay, prevention of aspiration. Here's something. Okay, it will help prevent gross aspiration. So if a person vomits, for example, it'll help. The cuff can help keep some of those major secretions above the cuff. That being said, there is this thing, it's called microaspiration, and there's aspiration happening all the time. So all those secretions that are sitting above the cuff, they have little grooves. The cuff, if you look at it with a microscope, you'll see the cuff is not completely flat and sealed straight up against the airway. There's these little grooves, and like bugs and like little secretions can kind of slide down around the outside of it. So it doesn't really prevent aspiration, but perhaps gross aspiration. If they vomit, it can be caught above the cuff. But there's microaspiration, there's aspiration happening pretty much all the time. Access to lungs for bronchoscopy. So in the event they have to perform a bronchoscopy, you can perform bronchoscopy, which is what I said, that scope. So it's like basically a long tube with the camera on the end. It goes down in through the trachea and looks around in the lungs, and they'll look around for things like cancer, or they can do therapeutic or diagnostic bronchoscopy, which we will talk about next year. But you can do it for those types of reasons. So it can be an access point for the bronchoscope because it's already in. You can just use it as a guide to get your bronch in there. Okay, so here is the endotracheal tube again. And so what you'll see here, here's the cuff. Okay, the Murphy eye, I don't know if you can see it. I've got my thing right over top of it, my little laser pointer. The bevel, there's a beveled tip, and right above the bevel tip is another hole in the tube, and they call that the Murphy eye. And my understanding is basically that could be used as an alternate ventilation port in the event that the tip gets like obstructed with like a mucus plug or something. Okay, all the tubes have a standard 15 millimeter connector, so you'll know that 15 and 22 millimeter connectors are extremely popular in respiratory care. Most of our things have a 15 millimeter connector, which would hook up to any standard manual ventilation bag. So that's great. So you don't have to have this type and that type in order for them to match it. They usually have standardized connections for any ambu bag, inline suction catheter, or circuit, ventilator circuit. And so the 15 millimeter connector should fit inside a 22 millimeter connector. And even still, they're just very common, two different common sizes that we use that help us fit most connections, okay? Each endotracheal tube has a radiopaque line, and this is what helps us to visualize the endotracheal tube on the x-ray. And I'm gonna go back a couple of slides because there was an extra piece on the other one. This piece here, this yellow thing, this is a subglottic suction port. So what happens in this particular model is there's a tube that goes down, it goes down, and it above this cuff, it has a port here. And so you'll hook this thing up to suction, and it will suction secretions that sit above the cuff. So they call it a subglottic because it's below the glottis, and it's above the cuff of the endotracheal tube, and it's a subglottic suction port. Okay, so that's when they say that, if some of the endotracheal tubes have that. Shucks, I just forgot like the trade name that they use for it. If I remember it, it'll come to me in a second. So that if you hear somebody call it that, you'll be like, oh yeah, that's what that is. So yes, you need to know the parts of the endotracheal tube. The other thing you'll note is that it is marked. So when you're trying to intubate, you know where to place the tube, okay? And once it's in, you'll be like, okay, it's at 24 centimeters at the teeth or at the gum. We never say it's at the lip. I don't care what you see in the hospital setting. I'm gonna tell you the best way and the only way that you should be marking it is at the teeth or the gum. Because let's say, for example, the person was in a fire or something happened and you say at the lip, and the next day their lips are out to here, you know, or there's some kind of massive swelling going on. Now your measuring is unreliable, okay? So, but your teeth and your gums always stay in the same spot, okay? So you have to measure it by that way. The other thing is the tube will mark what size it is, okay? So, so you need to be able to identify that on an endotracheal tube, like what size it is and the markings and all of that. Okay, so different cuff designs, alternative cuff designs. Normally our cuffs are a high volume, low pressure cuff. And if I look back here, what that means is once this cuff gets inflated, it'll kind of go out almost like in a rectangular shape. And I think I've talked about this in regards to tracheostomy tubes. What that does is it distributes the pressure over a greater surface area so that there's not one particular pressure point on the tracheal wall. That can lead to a lot of tracheal damage. So you want to have high volume, low pressure cuffs. I'm pretty sure that almost all endotracheal tubes nowadays are high volume, low pressure cuffs. A low volume, high pressure cuff would be more smaller, and so then the pressure would be distributed over a smaller surface area, which would be more pressure against the tracheal wall. Okay, foam cuffs. This is the exact same slide from tracheostomy tubes, by the way. So, oh, cool. Hold on a second. Sweet. My latte. It's good. It's so good. Okay. So the foam cuff is something that I've never seen a foam cuff on an endotracheal tube. That's not to say that they don't exist. Perhaps there could be some on some fancy, like maybe you're having some kind of fancy surgery or whatever. They do have some fancy endotracheal tubes that they will use for different types of surgery or like radiation therapy for cancer patients or something like that. But most cuffs that I've seen like on standard endotracheal tubes are just air cuffs. You can have some that you can fill with water, okay? But just FYI. Okay, so see it says here, low volume, high pressure cuffs. So some of them you can inflate with water, but other ones not air. But most of the cuffs that I've seen are just high volume, low pressure cuffs. Okay, so that's the endotracheal tube. Okay, when you're going to intubate somebody, you need to have the size of tube that you want to have, and then half the size down. They go in 0.5, so you'll have like 6, 6.5, 7, 7.5, 8, 8.5. That's how the tube sizing works. And so generally speaking, when you're preparing for intubation, you'll have one size tube and then one size smaller, and then that's to make sure that you, in case you can't get the one size in, you have one size down is generally easier to get in. Okay, now moving on to laryngoscopes. Okay, so these are the devices that we use to actually go ahead and visualize. Today we're talking about direct laryngoscopy. So laryngoscopy means you're like looking through the larynx at the vocal cords with using a laryngoscope, okay? They have video laryngoscopy. That is another fancy thing that we have nowadays to help visualize the vocal cords better. But this one we're going to talk about is direct laryngoscopy. So direct meaning we're directly looking in and looking at the vocal cords. So there's a handle and then a blade that comes, and the blade, at the end of the blade, there's a light that helps you to go in and see. Okay, it's really dark in there. So you can't just like go in and visualize. You have to like go in and you need a light, like a flashlight basically. to go in and see. So the two types of blades that we currently are using, and these are the standards that has been since I was in respiratory school, is a Miller blade and a Macintosh blade. A Miller is a straight blade, and this lifts the epiglottis directly. Okay, the Macintosh blade is a curved blade, and it goes in, and this is where the anatomy becomes very important. It goes behind the tongue, and it sits between the space between the tongue and the epiglottis is called the vallecula. So everybody say vallecula. Okay, that anatomical landmark is critical when you have Macintosh laryngoscopy, okay, and intubation. And I almost guarantee that you will be asked, that is a sputum bowl question, that is an NBRC question. Do not forget this, and don't look like a dummy. And they say, where is it supposed to sit? You're not able to say, you're gonna look like a total dummy. Okay, so you don't want that. So make sure you know it goes into the vallecula. And so what happens is the Macintosh blade is supposed to go in and sit in that space that is behind the tongue and before the epiglottis. And when you pull up the epiglottis, that's like this little flap that's sitting there. When you pull up, it pulls up the epiglottis with you. Okay, the Miller blade is a straight blade, it would go underneath it and pull it up like that. Okay, so they're just talking two different ways of getting the epiglottis out of the way so that you can see the vocal cords. And beyond that, you'll be able to visualize the cords and then go ahead and put your tube in. This is what they look like. Okay, here you can see this is your Macintosh blade. Notice the curve. Okay, and the Miller blade is straight. Okay, this handle generally has batteries in it. And then here's your little flashlight at the end. We're now starting to use disposable blades and handles so that you don't have to like go, because before we used to have to send these down to central sterilization, whatever I forgot. Oh my gosh, I'm having another brain fart about the name. SPD, sterilization processing department or something like that. And we would have to get them cleaned, and then we were reusing them. So nowadays we're looking at just using disposable blades and handles. So here's how you can tell which one it is too. See, that's engraved on the end. So this is a Mac 4, so that's a size 4. So they come in different sizes. 4 is the biggest, goes 4, 3, 2, 1, 0, and I think they have double 0 for like little babies. So they go from like, you know, like this size up to like, you know, that size. And this is a Miller blade MIL, and this would be, it looks like it's a size 2. So when you're not sure what size it is, you can look, it does tell you on the end of the handle and which size is the best. Okay, 3s and 4s are used for adults on both blades, but it's going to be basically physician preference or your preference. So depending on who's performing the intubation, and then that just depends on where you work. So you might say, hey, Mrs. H, like, or do we even do intubation? I said, possibly, yes. I know at some of the hospitals, we do the intubations. In the neonatal world, there's a lot of RTs doing intubations. In the adult world, maybe not. It depends on where you work. I think at Natividad and some of the teaching hospitals, it's really hard to get to do intubation because, you know, they want the residents to get all of the experience. But I was under the impression that they were going to be, if the resident couldn't get it, then respiratory was going to be the next person in line to try. So I'm not sure. It depends on where you work. But if you aren't performing the intubation, you are like the critical key player in getting all the equipment together, and you're standing right beside the physician, performing the intubation, and you're gathering all the equipment and you're setting everything up, and you always, whoever does the intubation, doesn't matter, we're the ones who secure the airway afterwards. So it's totally our thing. Here's a picture of how it looks when somebody's holding the blade. So you'll notice here, okay, it's held like a hammer, and you hold it like this. You always hold it in your left hand. It doesn't matter if you are right-handed, dominant, or left-handed. It's always held in your left hand. And you can see here, it's kind of a little groove right here, and it goes down. And that's supposed to be like a shovel to like get this tongue out of the way. So you go ahead and you insert it. So when you're looking at a patient, so you're holding it in your left hand, you're standing at the head of the bed, you put it in towards the right side of the patient's face or mouth, and then you move over towards midline, and that's supposed to kind of catch the tongue and move it out of the way, and then you go ahead and lift. So you always hold it in your left hand, and you have to be able to do that. Okay, here's a picture of a guy doing it here. You can see he's got the patient in the sniffing position, and he's got his laryngoscope in there, and you can see he's pulling up and out, up and out. You do not do this, okay? This is like an automatic fail on your competency. We don't do that. You go up and out, okay? Because you could break somebody's teeth. So somebody who goes in just to get, like, you know, knee surgery, and they're going to go in and get knee surgery and they come out with their knee but no front teeth, you know, that's going to be a big lawsuit, right? So we always trying to, this is a little bit different. It's not, you know, in the hospital scenario, we are worried about these things, okay? So you do not want to crank back on that handle, okay? And sometimes it might help with visualization, but if you're having struggling visualizing, you need to fix something. You don't just keep doing this to try to visualize. You've got to reposition the patient, or you figure out your technique or what you're doing so that you're able to make sure that you can visualize a little bit better, okay? So you got to try to do something different and fix something different. And if you're still not getting it in, it shouldn't be 4 or 5 different intubation attempts, because that's just going to, now they will become a difficult airway, because now that somebody's been jabbing in their throat all this time, they're going to be swelling up and this and that. So they have difficult airway algorithms, and I could share one with you. But generally, if you can't get your intubation within a couple of attempts, you should be trying something different, okay? And buying you some time until you can get something else done. Okay, this is a light adjunct devices. So here's some additional things that you can use to help you get this airway in successfully. So we have this thing, it's called a light wand. It's a stylet. So inside, so the stylet is a long, like, metal piece, and it goes into the endotracheal tube, and it helps provide some, like, rigid structure so that, you know, it's not just flopping around when you're trying to, like, get into the airway. That it's if you're trying to get it to the airway, that it's not, you know, going to be bending and stuff, because otherwise there's no, it's just a, you know, plastic piece of a plastic tube. So, like, it doesn't have, it's meant to be able to move, right? When the patient's intubated, they move their head around and stuff like that. So when you are doing the intubation procedure, though, you need to provide some kind of support to keep it from bending as you're trying to go into the airway. So a light wand is a stylet that can perform that function, but it also has the benefit of having a light at the end, okay? And so what it does is it helps when you are performing the intubation, you can see right away if you got into the airway, because it'll just light up the trachea. So you're like, okay, if you're in the esophagus, it'll be dim. If you're in the trachea, it's like, boom, you could totally see that you went in. So it's a way to help know whether you made it or not. Contraindications in the event that you can't turn off the lights, because if you have all the lights on, it doesn't really help. You can't really see it as well. And if they have thick necks, then the light doesn't transmit as well. So that might be one of the ways it's not as helpful. Okay, here's what it looks like right here. And so you can see, here's the light at the end, and you can see it's inside the endotracheal tube, and you can also use these stylets to help you shape the endotracheal tube to your preferred like shape. I like to shape mine like a hockey stick. Some people like them in a nice C shape, because again, you're trying to get around here and into the anterior space where the trachea is. So you want it to be like this. You don't want your endotracheal tube pointed the other way. The other nice thing is that it'll start to blink after a certain time frame. So I believe it's like 20 seconds, and then it'll start to blink. And so that way, you know, like, you should be kind of coming out and then reattempting your procedure again, because you're not supposed to take, you know, 3 minutes to intubate that whole time the patient's not getting breaths. So it'll actually start to flash and let you know when your time is up. Okay, this is a bronchoscope. I talked about this already. So a fiber optic bronchoscopy. There's a little light and a camera at the end of this thing here, and you can actually use it to direct. This tip will bend this way or that way, depending on the patient's anatomy and where you're trying to go. So what you could do is put an endotracheal tube over the end of this and have it sitting up here. And then you will go through the patient's airway, and you can directly see because it's got a camera on the end. And then you can see this is a little eyepiece here, and you could see yourself going in. So if they have a difficult intubation, or this is perfect for a C-spine, because you don't have to move the airway at all. It's just going to go through. You just advance the bronch into the airway, and then the tip, you can move the tip so you know you can see yourself going in. You can see yourself going through the cords. And the other nice thing is you can actually verify tube placement with this, because it's also marked, so you can tell everything by using bronchoscopy. You might say, why don't we use bronchoscopy for everybody? Well, they're not that readily available. These things are like super expensive and they're hard. So we generally reserve them for bronchoscopy procedures and also difficult airways. So if you have a difficult airway cart at your facility, you'll want to go and make sure you can see what's included in that difficult airway cart and be familiar with the contents. And generally there's a bronchoscope on a difficult airway cart. Okay, a double lumen tube or a combi tube is a tube that you can use to do independent lung ventilation. So let's say, for example, in this case, you can see here, it goes in and there's two cuffs, one here and one here. And so depending, this one you might actually intentionally intubate right main stem and then either ventilate just the right lung, or you can go through this other port and then ventilate the left lung. So you can do independent lung ventilation with a combi tube or this double lumen tube. Okay, so why would you do that? Well, depending on, you can see here, if they're doing a lung transplant or whatever, you can do that. There's also the king airway, which I think I talked about before, but you basically put it directly into the esophagus, and then you inflate that cuff and it seals off the esophagus. And then there's another big balloon that basically blocks off the oropharynx, and then you can ventilate the trachea that way because there's another port. I have some in the lab that you can review. Okay, that's the name of it, high-low evac tube. Okay, this is what I was talking about, subglottic suction. This is where you can provide subglottic suctioning. Here you can see the suction evacuation port, excuse me. And they're saying it's supposed to decrease the rate of ventilator-associated pneumonia. I don't know how true that is. Those things get clogged all the time. I don't know. So I think they are. We need to go and review what the latest research says, but they are supposed to help with removing secretions that build up on top of the cuff, which is nice. But the other thing is to reduce that micro aspiration that I was telling you about. Okay, so here's what the double lumen or that combi tube. I don't think the combi tube is actually the same thing. I have to go back and look at it, but a double lumen tube. So you can see here, you can ventilate the one port or the other port. Anyway, and I'm sorry, I was just thinking about something. So you can see it'll go into the one side, and then depending on which port you use, you can either go to this lung or to that lung. Okay, so that's the benefit. So you can do independent lung ventilation. Okay, the tube changer. Let me go to this slide first and then I'll come back. This is what it looks like. It's a hollow tube, and I can hook it up to some oxygen or an ambu bag. And so why would I use this? It's a very long yellow tube. It's a tube changer. Let's say, for example, I have an endotracheal tube that gets, the cuff is broken and I need to exchange the endotracheal tube. The patient still needs to be intubated, but my cuff is no longer working. So now I cannot ventilate my patient, because remember, gas flows the pathway of least resistance. If my cuff is down, it's going to be easier for the air to just go in and come right back out instead of going down into the lungs, okay? So in the event I have to exchange the endotracheal tube for whatever reason, it's better to use a tube changer than to extubate the patient, and then try to reintubate the patient. Because if you think about it, every time you try to reintubate, you have potential for not getting it in. Okay, so if you already have a tube that's in place, you might as well keep that, you know, that channel open. Okay, so what will happen is you'll use that tube changer, you will put that into the current endotracheal tube. You will then slide that endotracheal tube off, then take your new endotracheal tube and slide it over that one, the tube changer, and back into place. Okay, so it acts like a guide wire basically to keep the tube in, and then you just remove that tube exchanger catheter. So it helps to make sure that you can continue to keep your successful channel open. Okay, this piece comes off, so I can remove this when I'm in the process of changing out the tube, and then I can put it back on and give breaths. Okay. High volume, low pressure cuffs, the cuff pressure. So make sure that you maintain normal cuff pressures. Cuff pressure can create tracheal necrosis of the, and just a lot of damage to the tracheal walls. So you do not want to have that happen. So a patient should not have like permanent tracheal damage after being intubated. Okay, so here it talks about being kept below 25 millimeters of mercury. Normally we're measuring in centimeters of water. So remember, our cuff pressures for tracheostomy tubes are the same as they are for endotracheal tubes. So I believe it's 20 to 30 centimeters of water. Okay, if you do not have a cuff pressure manometer that will directly measure what the actual pressure is, you can use your minimal leak or minimal occluding technique, which we've already reviewed with you. So make sure you have reviewed that. But basically you shouldn't need more than like 5 to 7 cc's or mLs of air. So you'll use a 10 cc syringe, and like really should only take about 5 or so to fill up the cuff. Don't use all 10 and try to inflate the cuff as high as it'll go, because then you're going to have too high of pressure in the tracheal wall. Okay, this is the cuff pressure manometer and what it looks like. And so you attach the pilot balloon here. The pressure will be registered on on the manometer here, and then you can either inflate or deflate. Inflate by pumping air, squeezing the bottom here. It will add more air in, or there's a little knob on the side that you can touch to depress and release some pressure out of the cuff. So you'll target your pressure between 20 and 30. Here's what somebody looks like when they are intubated. So you have the endotracheal tube coming out, some kind of securing device, which we will teach you how to secure the endotracheal tube. You need to know how to tape and how to do ties. Okay, so you must know that. That is hands down the most biggest thing. Some people use these securing devices, and that's great. But in a pinch, and if you don't have anything, you need to know how to make sure. All you need is like a pen. I don't even need tongue depressors. I could just have a pen and a roll of tape, and I can secure an endotracheal tube. Okay, so that's what I want you guys to be able to do. It's a bit old school, but I think that's the best. And a lot of hospitals don't have their securing devices on their crash carts. So like I know at Chomp, for example, we have our crash carts do not have the Hollister ETAD securing devices. They have just the tape. And, you know, ideally for cost reductions and stuff, you don't want to use the whole, if they're going to be intubated for just a few hours, you don't want to have to use that securing device, because it just adds a lot of cost. So just go ahead, and we're going to tape the patient and also know how to do ties, so that no matter what happens, and if they're in a panic, because now there's no securing device, you do not need to panic. You know how to secure an endotracheal tube. It's no big deal for you. So the tube comes out. We have it hooked up here to a inline suction catheter. And then you'll see here that this is the start of the ventilator circuit. Okay, you're going to go over mechanical ventilation next year. Okay, so we talked about establishing the airway. So how you're going to go ahead and insert the airway. Okay, so step one. Okay, now we've determined, so you need to know what the different indications are and the complications to intubation. As far as I know, there is no contraindication to intubation because that's their airway. So if they'll die otherwise. So there, as to my knowledge, there's no contraindication unless they have a DNI order, which stands for do not intubate. Okay, so you're gonna check your equipment, assemble all your equipment. So you got to go through and review that. I'm gonna have my endotracheal tube that and one size smaller. You need to know the common sizes for males and females and common insertion depth for males and females. Okay, so that's something that you need to go look up and you have to know that. I'm going to check the cuff on the endotracheal tube first. Okay, so I do not want to put in a faulty endotracheal tube, and then that would really suck. So you always want to check the cuff on the endotracheal tube first. Then you're going to check your laryngoscope and make sure that the light works, because that also is terrible and it looks bad on the whole department if they're about to intubate and then they turn on, you know, they open the laryngoscope and now the light doesn't work. That's awful. And of course, everyone looks to respiratory, and it's like, it's just the absolute worst thing in the world. So don't let it happen to you, and you're going to make everyone look bad. So you always check the equipment, make sure it works. You're going to need suction equipment ready. You're going to need your manual resuscitating bag with a mask. Okay, and obviously your oxygen source, because initially you're going to bag the patient until they're ready to perform intubation. You may or may not bag, but then that, and then you will need your syringe, your stylet. You're going to need a way to detect whether it's in, so an end-tidal CO2, either a monitor or just the capnometer, the little color changer. And the way you can remember the color changer is that it's because it's purple and gold. And so if you're in, it's golden. Gold, you're golden. Okay. I forget what the P one is, but it's like if there is CO2 detected, it will change from purple to gold. And then that means you're in. Okay, so you're going to need your straight blade or your curved blade, depending on the preference of the person who's doing the intubation. Okay, so oxygen equipment, suction equipment, your endotracheal tube, you check the cuff, you've inserted the stylet, you've got your same size, your tube, and then one size down, and you've got a syringe ready, you've got your securing device all set up. And if you anticipate a difficult intubation, you're going to gather even more. So you go through and check all the equipment that you need. Okay. So a lot of the times it's just a setup and waiting for it to happen, and that takes like most of the work. And then the actual procedure itself should take like less than 20 seconds. Okay. So you're going to position the patient. The patient needs to be in a good position to maximize visualization of the vocal cords. Okay, we're going to pre-oxygenate the patient. So during this time, they'll either be on a non-rebreather mask. If they're still spontaneously breathing, they're on a non-rebreather mask or something like that. If they're not, you will be manually ventilating them with a high FiO2 in your manual resuscitation bag. You can have a PEEP valve, which we will talk about later, but this will be another thing that you might want for your ambu bag. So we're going to pre-oxygenate, make sure that the patient is, as the saturations are as high as possible prior to the procedure, and then they'll go ahead and give the drugs or whatever, if necessary, to give to the patient. Then when the patient's out of it, they will go ahead and a person will insert the laryngoscope, start to take a look. If there's secretions, you have to have the Yonker suction ready, and they'll suction out any secretions if necessary. Then they're going to go ahead and visualize the glottis. They'll have their hand out here. You hand them the endotracheal tube. So you hand them the tube as if in the way it's going to go into the patient. You don't give it to somebody upside down, right? You give it to them the way it's going to go in. The tube goes in. Okay. So inserting the tube. Then once the tube you think it's in, you're going to pull out the stylet. You are going to put the capnometer on there, the end-tidal CO2 detector. you're going to inflate the cuff, and then somebody's going to put the bag on the tube, and then they're going to give a breath, and the other person is going to be listening to make sure that it's there. So you want to listen over the tummy first. So we always recommend that you listen over the stomach first, because if you hear gurgling in the stomach, right away, you know you're not in, okay? Sometimes if the patient's perfusion is poor or whatever, you should see CO2 detection, but if you do not, you're like, and then you give another breath, and then you're like, wait a second, go again, and then you give another breath, okay? And some places, if they don't even have a CO2 detector, you have to rely on your other like skill. So don't let that be your only thing and like, I don't know if it's in or not, because you don't have a CO2 detector. You have to have your other ways of knowing whether it's in, okay? So my point is that if you listen over the lungs first, you can give like 1 breath, 2 breaths, 3 breaths, and then you listen over the tummy and you're like, oh crap, it's in the stomach. Now I've just given 4 breaths to the stomach. That's about 1 liter of air, if not closer to 2 liters of air that have now gone into the stomach. And what happens when the stomach is too full? Now I'm at much higher risk of vomiting and aspiration. So you definitely, and by the way, when you're doing the manual ventilation part, hopefully if you're doing a good job, and go back and review good technique, because again, I cannot stress enough how important good technique is for manual ventilation. But my point is that during that time, even then, even with really great technique, some air will probably still go into the stomach. Okay, so who knows how much air is in there. And so you absolutely want to try to listen over the tummy first. And then if you don't hear any gurgling, that's great. Then you also see it accompanied with CO2 detection on the little detector. That's great. The other way you can tell is by seeing chest rise and seeing bilateral chest rise. So if you only see unilateral chest rise, it means you've probably right main stem intubated the patient. But you want to see chest rise, and then you can also see some condensation in the endotracheal tube. That's from the exhaled condensation. So those are all signs that it's in the airway. Okay. Now, the other thing is, it says here tips of the thing, the tube, then when you're assessing tube position, you want to hear bilateral breath sounds, bilateral chest rise. The tube actually, it's 3 to 5. So change that, please. 3 to 5 centimeters of water. 3 to 5 centimeters above the carina. Okay. You will see that on a chest x-ray. One of the other things that they've talked about in terms of helping to, I have it in my notes here, they call it BURP, B-U-R-P, back, up, right, and pressure. And that helps to push down a little bit on the Adam's apple to help visualize the vocal cords a little bit better. So that might be something that you can do to help. Again, you cannot do that with the C-spine. Don't do it. But you should know what burp means. And somebody might ask you, can I get some cricoid pressure or some burp? And that means they want you to push down to help them visualize the cords better. Other adjunct devices. We have some forceps. They're called McGill forceps that you can use to help advance the endotracheal tube. This is for oral tracheal intubation. We'll talk about nasal tracheal intubation, I think, coming up. And that's where the McGill forceps will come in to place. But it's basically these little forceps that you can, because if you're going through the nose, you're not going to have this ability to advance the tube through the, like by pushing this way, you're going to grab the tube with the forceps in the mouth and advance it like that. I'll talk about that later. Here's that vallecula that I was talking about. Okay, so it's going to go in here, sit in here, and then pull up, and then that will push up the epiglottis, and then behind here is the glottis. Okay, so here's a picture of somebody just going ahead and getting started with this intubation procedure. This is a patient who has a maximal positioning, which is the best positioning, versus this patient here. This is going to be much more challenging to intubate than this position here. Okay, so as you are visualizing, this is what you want to see in here, okay? And again, I'm going to encourage you to review some YouTube or just some Google images of what it actually looks like on a patient, like on an actual person, so that you can see the cords. But you want to see those little pearly white vocal cords. Okay, they look like the inverted V, so that's what you want to see. You don't just attempt and pretend like, oh, that you're, hey, let's just hope that I get it. Okay, you're gonna go into the stomach if that happens. You have to see the vocal cords, and you should be watching your tube go through. So if you cannot see it, you take the laryngoscope out, you reposition the patient, you bag the patient, make sure everything's okay, and then you go and you try again to visualize. If you cannot visualize, don't pretend and then just kind of do a Hail Mary and hope that the tube goes in. Okay, that's not going to work out well for you. I can guarantee it. Anyway, this is what you want to see here. And this is just a picture of how the two different blades sit in the patient and how it just different ways of being able to visualize. Okay, so you just go ahead and develop. I don't know of any data that supports one is better than the other. It seems to be just all by preference. And so you'll just figure out which one you like better and use that. Okay, this is an example of a Macintosh blade. You can see here, it's sitting in the vallecula. It's going to pull up. Here's the epiglottis. And you can see it's when they pull up here, it's going to displace the epiglottis, and then you're going to try to advance the tube here into the trachea. Okay. Here's just some different ways of figuring out whether the tube is in position or not. So again, the light wand will light up the trachea. We used to use esophageal detection devices. We don't use those anymore. It was like a bulb that you would squeeze and empty the air and put it over the tube. And then if it reinflated, we were like, oh, it's in the lungs because it reinflates with air. We don't use it at all. Okay, it doesn't work at all. You shouldn't see, nobody should base that decision of whether it's in or not, because remember the tummy does have some air, so it'll re-expand anyway. So just never rely on it. Okay, tube length, observation of chest movement. Remember auscultation of the chest and the abdomen. The other thing again, you might see some condensation in the endotracheal tube unless they're hypothermic. They might not see it, but you'll probably see some condensation as well. Okay, nasotracheal intubation is more difficult because you're going through the nose. Okay, and I have a picture coming up. It's either doing a blind, it's like a blind technique that you go insert the tube through the nares, go down into the oropharynx, and then you're trying to visualize the vocal cords and advancing the tube that way. You can do it using laryngoscopy or using bronchoscopy. The steps are pretty similar, except instead of going through the mouth, you're going to go through the nose. And why would we do nasotracheal intubation? Well, generally in the event that the oral route is not available, like if a person has trauma to their airway, or maybe they're going to have a big facial surgery or some kind of oral trauma, if they're going to have some kind of surgery done on their face, on their mouth, then you'll want to go with nasotracheal route. Usually this is done for short term, like we don't want to have the nasal airway, and we don't want to keep things through the nose because people develop sinus infections. So ideally this is a short-term solution. Okay, this is what it looks like. So you have the tube going through the nose down into the oral cavity. You have the laryngoscope here. These are the McGill forceps that I talked about, okay? So once you're through the nose into the oral cavity and you see it kind of coming down, you're going to grab the endotracheal tube with the McGill forceps, and then using laryngoscopy, trying to visualize, and then you're going to advance the tube using the McGill forceps. That's how you'll do it. Okay, now let's say you can't use laryngoscopy for whatever reasons. A blind intubation could be done by the nasal route. Generally, they try to use breath sounds to guide insertion of the endotracheal tube, but blind pretty much doesn't work very well at all. Okay, so the primary indications include all of the following except, okay, and go ahead and pause and see if you can figure it out. And then I'm going to tell you what the answer is. So the answer is D, provide negative pressure ventilation. That is spontaneous ventilation, okay? So you breathe spontaneously by generating negative pressure in your lungs in order to create the pressure gradient required for air to flow into your lungs. So that's saying why we would never insert an artificial airway for somebody who's spontaneously breathing well. That's what that was kind of going for. Okay, so the capnograph or the capnometer, this thing is really great. So again, oh, they call it the easy cap. Okay, so if you see, oh, grab the easy cap. Here it is right here. And so it's a very simple thing. It's just based on color change. So it helps to confirm endotracheal tube placement. If it doesn't change color, then you're more than likely in the esophagus, okay? The only thing is, in the event that the patient does not have an adequate cardiac output, there might not be enough perfusion to the, lungs to actually have CO2 diffuse out and be enough to change the color of the easy cap. So here again, you never rely on just one thing. So this is where again you'd be like, okay, but I don't see color change, but I see bilateral chest rise, bilateral breath sounds, good saturation. I do not hear breath sounds over the stomach. You know, maybe there's condensation in the ET tube or not. You know, if there's condensation in the tube, then the color should change. But anyway, so just again, you use it in addition to your other things. Okay, so that's important. So again, just but know that these things the capnography relies on having enough perfusion to the lungs in order for the CO2 to diffuse out and to be exhaled out to register on whatever device. Okay, this is the esophageal detection device that does not work at all. Okay, so you're supposed to this is what you're supposed to do. You know, we used to have these on all the crash carts. Okay, so you used to depress the bulb, put it onto the end of the endotracheal tube, and then see, they're like, oh, if it reinflates, it means it's in the trachea. If it stays deflated, it means you're in the esophagus. Well, they never stayed deflated. They pretty much always re-expanded. So these have largely been replaced. Do you need to know what it is? Yes. Could it be asked on the NBRC? Yes. Will you see it in the clinical setting? Highly doubtful. Okay, highly doubtful. Some places I think we're still keeping them on their crash carts, but I would not rely on this. Again, remember, this is just one thing. You have to look at the overall clinical picture to make sure that you're in. Okay, auscultation, perform at least 3 areas of the lung and the gastric area. Again, make sure, okay, here's what you want to do. You're going to listen over the tummy first, then you're going to go here, then you're going to go here, okay? And so if the patient has a ton of secretions, remember that copious amounts of secretions is an indication for intubation. So you can have lots of secretions and cause crackles, okay? But what will happen is if it's in the stomach, it's louder in the stomach than it is in the lungs. Okay, so that's how you can tell. Because it says, okay, gastric sounds can be mistaken, because you'll listen, you're like, wait, that's why I say listen over the stomach first, because you'll be like, you know, you're like, whoa, okay, so I don't see chest rise and I hear, you know, over the tummy. That means it's in the tummy. But if you start here and you're like, wait, huh, and I can hear it because I can hear crackles, but what you're hearing is the sound of the tummy being inflated and it's transmitting up to the lung. So that's why we like to start at the stomach, then do 1, 2, and then 3 and 4, okay? So if you don't, and if you hear something, but then you go up here and it's much louder, then that means you're still in the trachea, okay? So again, you got to rely on all the different indicators to let you know whether you're in or not. Okay, bronchoscopy can completely verify tube placement, because I mean, you know, when you're going into the trachea, you see yourself pass through the cords, you know that you're in, okay? Then you can also use it to confirm tube placement because they can actually go down to the level of the carina and then withdraw and then verify placement. Okay, now that you're in, let's say you got in, and now what? So you have completely bypassed the patient's upper airway. And remember that the upper airway function is to heat, humidify, and filter inhaled gases. So you've completely bypassed those functions. So you absolutely must provide some type of humidification to the patient. Okay. By the way, stepping back, I don't know, I think I have some slides coming up on securing, and I will talk about that in a second. Once the tube goes in and they pull out the stethoscope, they inflate the cuff, they pull out the stylet, they inflate the cuff, we got the CO2 detector on, the ambu bag goes on. Somebody needs to be holding that tube, okay? You need to hold that tube and you do not let go until that tube is secured, okay? That is just like with tracheostomy when you're changing the ties that you cannot let go of the trach. Same goes for this. When that tube is not secured, that is their airway, okay? And remember, they've been sedated and paralyzed for this process. If something happens to that airway, they could die. You hold that tube, okay? If you let go, that's an automatic fail on the competency. Okay, now moving back to this, you've established it, tubes on, blah, blah, blah. And now we've got to provide some kind of a humidification. You have to, because you bypassed the upper airway. So what we could do, this is a picture of an HME or heat and moisture exchanger. So this is a passive system. What that means is that it basically, the patient exhales all of the heat from their body temperature and the condensation in their exhaled gas gets trapped in the little filter that's in here. And then when the next air comes in, it picks up that heat and moisture and passes it back to the patient. So it's kind of using the patient's own heat and humidification to rehumidify and warm the next inhaled gas, okay? So generally speaking, when we initially intubate a patient, we more than likely put them on this unless we have a reason to go straight to a heated system, we will use this. Reasons to go straight to a heated system are there's like copious thick secretions, or if you know they're going to be intubated for a super long time. But generally speaking, patients are pretty much extubated within a few days. So most patients can be managed with this HME. Okay, HME for short, it stands for heat and moisture exchanger. You need to know that and be able to spell it. Okay, so active humidification includes heated system that we will talk about in mechanical ventilation, but this is where instead of it being trapping the patient's own exhaled gas, another reason to do this in addition to like copious thick secretions would be hypothermia, and you're trying to warm them back up. The HME doesn't provide enough heat and moisture, so you would have to provide an active heated system. So this is where they like have a water trap and they heat it up and then that passes over. Humidifier passes. It's a passover humidifier. Go look that up if you don't know what that means. Okay, so airway trauma associated with tubes, tracheostomy or endotracheal tubes. So now you can see that you're starting to get some lower airway stuff. So some of the complications with OPA, NPA, laryngeal mask area or LMA, those are upper airway stuff. Now we're starting to add some lower airway or beyond the glottis stuff. So vocal cord paralysis is now something, vocal cord ulcerations, glottic edema, those kinds of things are potential complications. This is the same slide as the tracheostomy tube because again, they're artificial airways. So all the same complications apply. The different one would be stoma. Like with endotracheal tube, you don't get the complications with the infection at the stoma site, but you can still get infection. Okay, this is flow volume loops. This one is your tracheal stenosis here. Okay, fixed obstructive pattern. So you can create tracheal stenosis, which is a narrowing of the tracheal diameter because of scar tissue or whatever that build up over time as a result of having constant damage to the tracheal wall because of the endotracheal tube or tracheostomy tube. Treatment depends on the severity, especially the type of injury that you have. Like you could have vocal cord paralysis, and that could be one side or both sides. That could be temporary or permanent. And they'll just have like a funny voice for the rest of their lives. You can, tracheal malacia was one. So all the same ones from tracheostomy tube apply here as well. So go ahead and review all of those. So what they could do is they could put an airway stent to try to keep the airway open. Granulomas could be surgically removed or like using a laser therapy. They may or may not do anything for it. I don't believe there's anything you can really do for tracheal stenosis. Perhaps it's some kind of a surgical thing, depending on severity or, how bad it is. So what can you do to prevent this from happening? Well, the primary reason that people get these injuries or these complications is because of tube movement. So it's excessive tube movement. So you need to have the tube in the right place. You need to have appropriate cuff pressures, and you need to prevent it from moving around. So if you're having like the tube, all this moving up and down, so if it's not secured properly, it can move up and down and really cause a lot of damage in there. So you want to make sure that it's secured properly, and you want to avoid pulling on the endotracheal tube or the tracheostomy tube one way or the other. So this means like, keeping the circuit and everything nice and up so that it doesn't pull on and pull down on the patient, okay? So they can see here a swivel adapter can reduce the tube traction. So some of these swivel adapters, especially on the trach, it allows the circuit to kind of move up and down so that it doesn't like pull up and pull down on the tube. Sedation can help avoid self-extubation, because as patients, again, you have a endotracheal tube in your airway. This is very uncomfortable. It is not natural at all. So as soon as people start waking up, they're going to start reaching and trying to pull it out, and they're not with it. They're totally under a lot of sedation. So we want to try to perhaps keep them like slightly sedated, just to help them tolerate having the tube in. That said, the other thing you do is we evaluate as often as possible whether that they can get the tube out. So that's why we do spontaneous breathing trials every day, if possible, to try to see as soon as we can get the tube out, we want to take it out. Although nasal tracheal tubes are easier to stabilize, they are not good because they can cause sinus infections, which are really bad. And then it says here, maintaining pressures, 25 to 35 is not correct. I'm sorry, put 20 to 30, please. Okay, and then the correct airway size is important. You don't want to have a tube that's too small, and you don't want to have a tube that's too large. That's why you got to go back and remember the correct sizes for males and females. Okay, so again, high pressure, high cuff pressures compress the little capillaries on the tracheal wall. That leads to tracheal cells dying, necrosis, and that can lead to a whole bunch of problems. So that's why we want to make sure that we don't create permanent damage to somebody's airway from having them intubated. Okay, so you have to maintain appropriate cuff pressures, enough to do what it is intended to do, but not overinflating the cuff and not over having too much pressure to hurt the airway. Okay, other complications of intubation. So again, you can knock out someone's teeth if you're not doing correct technique. You can have damage to the soft tissues of the lips and the mouth. If you're like pinching the lips and the mouth, they can get a fat lip after it. If you're in there and you're just kind of trying to get it in, you'll be jabbing the vocal cords. You can cause vocal cord injury. You could do all sorts of damage to people when they are getting intubated. So many problems. And that's why if we can manage these patients non-invasively, that's what we're going to do. Okay, other types of problems, vagal response. If you hit the vagus nerve, which is right by the carina, you can cause a vasovagal response, which will cause bradycardia, ventricular arrhythmias, hypoxia. If we're taking too long and we're not able to get the airway in place, the patient can become very hypoxic. If we are over ventilating and using too high of pressures, that will cause the patient to vomit and aspirate. It's not a question of if it's going to happen to you, it's a matter of when. Everyone during an intubation procedure will see somebody vomit. What you're going to do is you're going to turn them to their side and you're going to try to just suction that out. That's why you have to have suction equipment available and ready to go. Okay, so you can see here's a whole list of problems. Okay, our role is to secure the tube. So we're going to either be performing the intubation or helping with the intubation, one of the other. So we are responsible for all the equipment, no matter who's doing the intubation. Respiratory is always responsible for all of the equipment. So make sure you know your equipment and you know that it's working. Once the tube is in, you will secure it, okay? They talk about providing for patient communication. So if the patient's like in ICU and they're awake, we usually, if they can, we'll give them a little writing pad. The other thing for communication is you never ask open-ended questions. Never ask an intubated patient open-ended questions. It's just going to lead to major frustration on everyone's part, and it's terrible, okay? So, for example, how's your breathing today? No. You're going to say, are you having trouble breathing? Yes or no. So think of things that you can ask that are yes, no type of questions. So that's all they have to do. If you see and they're kind of fidgeting, generally speaking, they have an itchy nose or they're in pain, you know, things like that. Sometimes people will be reaching up just to try to scratch their nose. And because they're reaching up, you think they're going to try to pull the tube out. So everybody runs in and does it. And then next thing you know, they're restrained and this and that. And all they wanted to do was itch their nose. So try to do some troubleshooting and communicate with your patients. They cannot talk to you and you cannot read lips. They also have an endotracheal tube in place. You cannot read their lips. It's awful, okay? And then they just get frustrated and disheartened, and it's really sad to leave them in the room when they're like that. Sometimes the nursing is better at reading lips than we are because they're just with the patient so much, so they get pretty good at that. But just, you know, try to do some troubleshooting. Are you itchy? Are you uncomfortable? Are you in pain? Does this feel better? Does that feel better? You know, are you wondering where your family members are? Do you have to pee? A lot of times they have to pee or poop and they forget that they're in an ICU bed and they don't realize that they have a catheter. So you could tell them, like, you have a catheter, you know, and they're embarrassed. I mean, these are people too, like they don't want to poo in the bed, you know, they don't want to do these things. So you have to kind of just say, oh, it's okay. And you have a catheter in your bladder, you have a catheter that will, you know, if you need to go, you can go ahead and just go, right? So, you know, communication is really important. Making eye contact with them is really important. So don't just like be looking off to the side. If you're going to do something, you know, go ahead and take a look at them and let them know. You know, of course, depending on cultural sensitivity and all of that, but like a lot of patients will appreciate that. We had one lady who came in and talked to our students a long time ago about communication. She was intubated for a few days after an anaphylactic reaction to shellfish. And she told us that, you know, when the RT like looked at her and was walking her through her spontaneous breathing trial, she said she felt like they actually were really helping her. And it made a big difference for her because they weren't just like kind of half paying attention to her while they were going about all their other chores, right? So really kind of try to make that communication piece more satisfying, and you'll be more satisfied and the patient will be more satisfied and ideally get their needs met. Okay, ensuring adequate humidification. They absolutely must be on some kind of humidity. So you're gonna evaluate that with an HME. If they have thick secretions and they're not gonna get extubated, then change them over to a heated system if you're not able. If their secretions are getting more thick and more difficult to get rid of, then they might need a heated system. Okay, so minimizing the possibility of infection. This goes along with things like keeping the head of the bed elevated 30 degrees. That's one of the things. We have all these ventilator-associated pneumonia or ventilator-associated events protocols where we do like oral care. You only suction when necessary. We minimize breaking of the circuit. adequate cuff pressures and keeping the head of the bed elevated and some other things to try to minimize infection and getting the tube out as soon as possible. Okay, we have everyone's hooked up to a suction catheter for the most part, in an inline suction catheter, and so we will perform suctioning as necessary. We do not routinely instill normal saline for suctioning. We do not want to do that. That does not help at all. And cuff care, and then we're going to troubleshoot any type of airway problems. Okay, go ahead and see if you can answer this one. Serious complication of emergency management include all of the following except. Go ahead and read through this and ask yourself, what are they? Then say yes, no, yes, no. So you're looking for the wrong answer here. And so the correct wrong answer is B, hypocapnia. Hypocapnia is low carbon dioxide. Emergency airway management, you would have hypercapnia. You would not have hypocapnia. So they're having inadequate ventilation. That's why they're getting intubated. So I've never seen somebody get hypocapnia from an emergency airway management. Later on, they can get hypocapnic because somebody goes and bags them like, you know, you don't want to be bagging them like that. Okay, you're gonna just do your bagging the best that you can and not overinflating the lungs. Okay, so this is the exact same slide as the tracheostomy slide. So tube obstruction, a kinking or biting of the tube, that's patients when they wake up. So we also have bite blocks that we can insert to keep, if they are biting down, because again, they're sedated, they're not really knowing what's going on. So they're gonna bite because there's something there, and that's just like a natural reflex. So we can insert a bite block to help doing that, to help with that, excuse me. And cuff herniation, that's something that can happen. So, you know, this is how you would resolve that airway emergency. Mucus plugging, again, you'll want to suction it out if you can. If you cannot, you might have to emergency airway replacement. So you're going to have to figure out different things. So I want you to know the different airway emergencies that you can have and what you need to do. Okay, cuff leaks. Oh, here, this is just a picture of, you know, the different types of airway emergencies. So, you know, FYI. Cuff leaks would be pretty difficult because in the event that they have a cuff leak, it will reduce the tidal volume delivered because some of the air is going to want to escape out from around the cuff. Okay, so you would just add more air or check the cuff pressure. Also check the tube placement to see if it's in the correct spot, because sometimes if it moves out, that could be a reason for the cuff leak. It could be that the tube is not the correct size. Okay, so if it needs a ton of pressure to maintain a seal, that means probably the tube is probably too small. But if it's just a tube leak, then it could be that they just lost some air out of the tube. So check the tube cuff pressure and then check the tube placement. If it's the ruptured cuff or the pilot valve is not working, then you're going to have to replace the tube probably. They also have pilot valve repair kits that you can do. A ruptured cuff is just you have to get the tube back in. So ideally you'll want to use the endotracheal tube exchanger and use as a guide to get the new cuff in place. The new endotracheal tube in place, excuse me. So make sure you know how to do those troubleshooting and potential solutions for those issues. This is just a nice algorithm to help you walk through, like, what do I do in the event that my cuff pressure is all messed up? If you're also having to continuously inflate the cuff, it could be tracheal malacia. That was one of the things for tracheostomy tubes. And that's basically a softening of the cartilage rings in the trachea that got soft from excessive tube pressures and stuff like that. So know the different complications. I'm not going to walk through the algorithm. You can go ahead. That's for your viewing pleasure. And I think you should know how to do it. Accidental extubation. So remember, on a tracheostomy tube, it's called decannulation, and on an endotracheal tube, it's called extubation. So an accidental extubation is if the tube comes out, like let's say it wasn't secured properly or whatever happened, and it starts to come out. What you're going to have is you're going to hear some gurgling probably. You're going to have some decrease in your breath sounds and perhaps difficulty suctioning or not. You can hear some air flowing through the mouth or the nose. And if you hear any, noise from the patient, like their voice, that's not good. Okay. So you're going to that's not good. Okay. What do? You can't just shove it back in. It's more than likely not going to go back in. If it's just like slightly out, you're like, okay, but if more than likely, if it's out, it's out. You just got to take the tube out, manually ventilate, or, give them oxygen and see how they do and evaluate whether you need to reintubate or not. Okay. If they're breathing spontaneously, you can give them oxygen and see how they do. And then if necessary, and they need help with ventilation, you will manually ventilate them. If they're not breathing spontaneously, then you need to manually ventilate them. Okay. So always make sure, always make sure that your ambu bag with a mask and a syringe is available and easily accessible by you, okay? Because it doesn't help anyone if it's behind like 3 IV poles and now you can't get to it and the patient's desaturating while you're trying to get to your ambu bag, okay? So you have to be able to get to it. This is where I would show you in class how to secure the airway. We will do the taping exercise in lab. Okay, so extubation / decannulation, this is when you are intentionally removing the endotracheal tube. So why we are trying to evaluate and do this as quickly as possible on every patient. We do not want to leave an endotracheal tube in place for anybody if they don't need it. So extubation is and you have to be able to pronounce it and spell it, okay? Extubation is the process of removing the airway, oral or nasal endotracheal tube. Decannulation when you're removing a tracheostomy tube. But today I'm talking about extubation. So you're going to first make sure that they're ready, because you want to be sure that the patient's able to sustain ventilation on their own and also be able to protect their airway. Okay, so how do we know if those things are there? The original problem is no longer present. Let's say they had a big pneumonia that caused them to go into respiratory failure. Well, they've received their antibiotics and whatever else, and the pneumonia is cleared and they sound good. So the original reason why they got intubated in the first place is now resolved. Okay, so that's one thing. The quantity and thickness of secretions. Well, if they have manageable secretions, if they have unmanageable secretions, you're going to pull that tube out and then they're going to need to get reintubated because they're going to be drowning in their secretions again. Okay, so even if they have a strong cough, but they're just, the amount of sputum production is just too much to overwhelm anybody, then that's just, they're not ready, okay? Upper airway patency. So what we generally do is when we're assessing and doing prior to extubation, we will do a cuff leak test and we will suction above the cuff and then we will deflate the cuff and see if we can hear gurgling or a leak. And so if you hear a leak, that means that air is passing by the cuff. So you're hoping that their airway is patent at this point, and hopefully they will not develop post-extubation stridor. But if they do not have a cuff leak, then I would question whether they're ready. We've had people not have a cuff leak, and then they might give them a dose of steroids, and then they'll go ahead and get extubated later in the day or something. But you want to make sure that they have a cuff leak present and presence of an intact gag reflex. So remember, a cough and a gag are the things that will help the patient protect their airway. So sometimes prior to extubation, we'll go in orally suction and go back kind of far to see if they gag, and you're like, oh, sorry, but really you intended to do that to be like, okay, check, they have a gag. Okay, so you don't want to keep gagging them so that they throw up, but just like one time, go back there, apologize. But then in your head, you're like, that's great, because now I have an intact gag, I'm happy. and the ability to clear secretion. So this is by having a strong cough. If they have a nice cough, that's good. And you assess that while you're suctioning the patient. So those would be all items that would tell me that the patient's ready. And then again, making sure they have enough muscle strength that they can successfully ventilate themselves. Okay, so assembling the needed equipment, I'm going to get more suction equipment ready. I'm going to get my whatever oxygen device, I'm going to put them on, ideally with some humidification after, you know, re-intubation equipment if it's needed, those kinds of things, or if I anticipate them needing to be re-intubated, and you never really know. So it's not a bad idea to have intubation equipment ready in the event that things go bad. So I'm going to just basically what I'm going to put them on, I'm going to put a towel on their chest. Next semester, you'll do extubation. So, you know, you'll review this again, but basically you need to have your syringe ready, your manual ventilation bag with mask, suction equipment, and whatever you're going to put them on for oxygen and humidification after. Okay. So we're going to suction the patient above and below the cuff. So we're going to suction endotracheal suction and then orally suction to try to get any secretions above the cuff. We're going to hyperoxygenate the patient. You will then loosen up all the securing devices and deflate the cuff, and then you will go ahead and remove the tube and then put them on their whatever oxygen. You're going to, you know, have them sit up and cough, and then you're just going to basically listen over the lungs and the airway. You always listen over the airway, okay? Always. Okay, and so there you go. During extubation, you want to extubate at the peak of inspiration. So what will happen is you'll be like, okay, are you ready? They're like, yeah. And then you go, okay, big breath, and you go, you know, usually like we take a couple of deep breaths, we go one, and then so as soon as they go on exhale, you go, and you pull the tube out, and then that way they're kind of like coughing it out at the same time. So that does it for intubation. We will do some practice in lab, and thank you very much.